Well, welcome everybody. I hope everyone is well. This is a Tuesday afternoon. We're doing the another remote webinar, VITA Learning webinar. Today we have Dr. Julian Conejo out of UPenn. Today's topic, digital dentistry, strength through adhesive bonding. Just before we get going, how are you doing, Dr. Conejo? Are you doing well?
Yeah, doing excellent, Jim. Good to see you here.
Excellent. So just a couple reminders to the audience. Everyone's phone is on mute. So on the right-hand side of your screen, once you've signed up, there is a panel. Go to webinar panel, and under that panel, there is a question board. So if you ever want to, you can type in your question. We'll be doing the questions at the end of the program. But go ahead and type in all your questions, and then we'll get to those. So again, your phone is on mute. The Q&A will be at the end. This will be recorded as well, like all of our VITA Learning webinars. So it'll be recorded. It's found on our VITA YouTube channel. And you can also learn more at our VITA websites. So please join us for those other remote webinars that we've done with Dr. Conejo and others. I think, Julian, this is probably the 6th, 7th webinar we've done with you and all sorts of different topics.
Yeah, I think this is the 6th and the last one scheduled for the year. So it's been a very active year with this format, and happy to hear a lot of feedback and interactions after the webinars.
Yeah, and we're going to be soon going into another year, 2022. We'll continue to do these remote hybrid type webinars along with some, hope to get out there along with you out in the field and do some physical hands-on, which would be nice for all of us to get out and, you know, visit each other in personally. So that's a good thing. So we are going to go ahead with this webinar today, November 16th, again with Dr. Julian Conejo. Welcome to the VITA Learning webinar. Today we are going to talk about digital dentistry and strength through adhesive bonding. Dr. Conejo obtained his DDS from the Universidad of Latina, Costa Rica in 2005. I messed up that whole, I'm not a Spanish speaking person, so even though I'm in California, sorry about that. And then completed his training as a prosthodontist at the Intercontinental in Mexico in 2008. Is a visiting scholar at the Department of Preventative and Restorative Sciences, University of Pennsylvania, Philadelphia, UPenn, which is a fantastic school. You guys got a great curriculum for CAD/CAM. Is that going well still, that the whole line of having your students mandatory do some CAD/CAM digital work?
Yeah, absolutely. We're very active, and actually today we had a full day in the digital lab doing hands-on and going through important aspects of designing. So yeah, it's up and running.
Nice. They're probably taking that on fairly well today. Today's new dentists, prospective dentists.
Mm-hmm.
And then practice. Dr. Conejo also practices clinical dentistry and conducts extensive research at UPenn. He's also the clinical CAD/CAM director at UPenn as well. And from his research and experience has written several peer-reviewed articles and studies. So I'm going to go ahead and turn this over to Dr. Conejo. And just give me a few minutes. I will turn this over to you. Dr. Conejo, you are now the presenter. So we should be seeing your screen soon.
Mm-hmm.
Yes, there we are.
Okay.
All right. So thank you very much for helping us out with this, Dr. Conejo. And I will go ahead and get my photo off the grid, and it's all yours. So thank you.
Great, Jim. Thanks a lot, and we'll chat for the Q&A session after the presentation. So I would like to welcome everyone that is joining us this evening or afternoon, depending where you guys are. And I would like to thank you for the spending the time with us. And I would also like to thank Jim for moderating all these series of webinars through the year, and of course VITA North America for providing this platform as well. And today I would like to present the last webinar scheduled for this year on what I do mostly, which is digital dentistry, and summarizing and going back to some important concepts on material selection and adhesive cementation for longevity. So now I'm trying to focus on clinical success and longevity. That's my main focus. Of course, not everything brand new. We know if it's going to really last what we intend our restorations to last. So with that being said, we'll get started. And as Jim was saying, we try to publish and keep ourselves up to date with so many new materials out there for chairside CAD/CAM dentistry or for laboratory use as well. And I'll try to summarize some of these concepts we've published with new cases and new material that I haven't shared before, trying to always keep new material and make the presentations innovative as much as possible every single time. So as a quick history or background, I am a prosthodontist from San Jose, Costa Rica, and I started working with chairside CAD/CAM dentistry in January of 2010, specifically with the Cerec system with the blue cam. And once I got into this, I said, well, I need to get this going. As many of us, it's a big investment. It's a big, risk. Maybe initially at that time was of course something not as common as we have now, and we've seen many things work great through those 11 almost 12 years, and many things not work that great, and that's some of the things that I would like to point out and combine both some research that we do with also clinical experience. I think that's always our focus point, that combination. So from what we do today and have been doing for years, the quality on our preparations, the quality on the scans are the base, the foundation for everything we do later on. Nowadays, we want to spend less time designing, and I think to be able to use what the softwares have nowadays, we got to go back to basics, improving our preparations, prepping even better, understanding exactly what the software wants to be able to have a smooth design and a smooth transition to the milling and finishing processes in order to deliver better quality of chairside CAD/CAM restorations. So just to summarize my material selection perspective nowadays in finishing 2021, we have this publication where we just try to divide all the materials that are out there in three main groups. We will go from resin matrix ceramics, specifically talking today a little bit about hybrid ceramics, V-dynamic, and then on the silicate ceramics, talking about Phosphatic Ceramics. Now we are celebrating the anniversary of the VITA blocks, the first material to be there out for a Cerec system, and still something that I wouldn't think about not using for high aesthetic restorations. Newer players in the world of the lithium disilicates, I'll mention some of this, and then also how we are seeing the near future with newer versions of zirconia also for the chairside dentist as well. So I had the opportunity to visit VITA Tan Fabric in Bad Sacking this year, and spend some days doing some webinars for the anniversary of the VITA blocks. And from an update for us, now we have them available in brighter shades, in bleaching shades. As you can see, these photos, I took them when I received, very excited, the OM1 VITA Trilux Forte block. So we don't need to go to a monochromatic block when we want these brighter shades. Now we have that steel diffumination with more, let's say, less chromatic and more translucency to the top of the block, and try to have something that has that gradient as it comes out from the milling machine, and spend less time staining and glazing. So we will talk about the Phosphatic Ceramics, because steel is the most translucent material. This is great for certain clinical indications where the color of the abutment tooth is ideal, where the size of the abutment tooth is also in a way symmetric to the contralateral teeth. When we're working multiple anterior restorations, that's something we have to consider. We understand that this material relies on adhesive cementation and thickness, so must be adhesively bonded. And what it's great, it's polychromatic versions. Personally, I use the VITA Trilux Forte. That's the version from the 3 different VITA blocks on Phosphatic Ceramics, like the Mark II monochromatic, VITA Trilux multichromatic, and also the real life, that it has a different 3-dimensional composition between like a more dentinal core and a more of a dome on enamel. And we'll show a few screenshots of that version as well. So when we started working in the Cerec system in 2010, we basically were using this material for everything. The material is indicated for, of course, partial coverage restorations like inlays, onlays, veneers, and full coverage restorations, anterior and posterior crowns. So there's a lot of scientific evidence showing how this material works excellent when we have 2 conditions. 1, when we respect the minimal thickness, and 2, when we assure proper adhesive cementation. So would I use it for every single posterior crown nowadays? No, probably not, but wherever I have a posterior tooth with healthy dentin and enamel, and I know that I can apply a bonding agent, partially etch that enamel, and have a good adhesive cementation, that will be something that will work wherever in the mouth. Okay, so if I have a lot of different core materials in that tooth, from amalgam or metals, or no enamel rim around, just a dentin and or a core buildup material, then maybe the bond strength is not going to be the strongest one. So maybe then I will go for a material that gives me more flexural strength by the material itself. So this type of case-by-case brief analysis of the situation, I think, are very, very important. So these I took from the VITA website, and for the phosphatic materials, even for the posteriors, can be used, but we need a shoulder of 0.8 millimeters. Then in a molar is not that aggressive, I would say. We make that relation. And then important minimal thickness at 1 millimeter in the center fissure. And if we could go 1.5 all around, that would be better, because the restoration will be always as strong as its weakest link. So if I have one part that is only 0.8, that will dictate the overall strength of my restoration. So those are some numbers that are not negotiable for the posterior segment with phosphatic ceramics. For the partial coverage, same applies, minimal 1 millimeter. Ideally, if we could standardize that with 1.5, that would be even better with the additional adhesive cementation protocols. So I'm very excited every time I go back and see my initial cases, and these 2 partial coverage restorations. I didn't put today all the photos on how I accomplished this, right? But it was with some spray and the blue cam and doing one restoration at the time, and many things that we don't even think about today. But having a preparation that has a soft transition, having a preparation that has significant reduction, but most importantly, anatomical reduction, considering the opposing dentition, will make us have this type of longevity with Phosphatic ceramics, independently in the position of the mouth, whether it's a second molar or a central incisor. Rubber dam isolation to really control the humidity and contamination. I think it's a must when we're trying to work with Phosphatic ceramics in the posterior region. So I don't want to go too much today into research, but just taking a quick look at some of what it's published there from many years ago. Chairside Cerec, AC, ceramic restorations, clinically successful, 95.5%. So that's very, very high, comparable to any other materials that might have a higher flexural strength, because there are always different types of complications in dentistry, as you all know and see on a regular basis. So important to understand that the fracture rate of ceramic restorations was significantly more common in non-vital teeth compared to vital teeth. So going back to what I said at the beginning, analyzing what I have in that tooth, the amount of the surrounding enamel rim, fresh dentin, we know that might dictate the longevity of my restorations with Phosphatic ceramics in the posteriors. So then we also tried the VITA Real Life, which had or has that internal, let's say, core, that pyramid of more dentinal type of ceramic covered by this dome of enamel. And then we had to try to position these accordingly to what we have in the adjacent teeth to really have something that match the natural tooth. But honestly, on a regular basis, I used VITA Trilux Forte. I like that version of the polychromatic block for every type of anterior or posterior restorations. And here is one example using the VITA Real Life. I think this was one of my first publications, maybe in 2011. And this is a bicuspid. For those of you with more experience in the Cerec world, you can see the screenshots and assure that this has at least 8 to 9 years based on the software version. But you can see there a nice bicuspid, just milled and polished without any need of staining or glazing. So that's a high valuable asset, I would say, that Phosphatic ceramic has. It has a dimensional stability. What you mill is what you get. What you mill is what it's going to look like. So you have a very quick turnaround. And then if the specific situation demands staining and glazing, more in the anterior segment, more adjacent teeth with heavily characterization, then we will go, of course, with the Accent Plus and go and personalize more that restoration. But many posterior restorations, we used to just polish and use this block for that natural blending. So after working many years these materials and having, of course, high success, but also having specific cases where we saw some fractures, like with any other material or complications, we understand that it's us, the weak link. My clinical work, sometimes I want to perform excellent, but some other days I might be performing okay, and maybe I think I have occlusal clearance, but when I design the restoration, I see that minimal thickness warning and I try to ignore it. I try to reduce the parameters so I can continue. So we designed this CAD/CAM burr block with Brasler, thinking in all the possible mistakes we've seen or we've made ourselves, trying to have a set of instruments that will help me have thickness where it's needed. Thickness in the center fissure, in the molar region. That's why we have this second burr here. We want to have smooth transitions between the proximal surfaces and the buccal and lingual walls. So we have an easy path of insertion for our partial coverage restorations. Of course, burrs that are short, so we can maneuver very well in the region of the first and second molar, where space is something that we many times don't have. And then have in the same burr block the solutions for veneers, which we do more and more nowadays, and full coverage anterior crowns, mainly when we are replacing existing crowns or treating endodontically treated teeth, right? So having this has been something very helpful for us, and it just makes everyone have better results because we can control the depth of what we're cutting, trying to keep as much enamel as possible because the longevity on the bonding to enamel is still superior to the longevity of the bonding to dentin. Then making sure that we have burrs in a fine diamond that will give us the best possible finish line, and these ultra fine diamond to basically smooth the prep out, smooth those line angles in the preparation that we don't want to have, and then you will be start to see the intaglio surface of your milled crowns or partial coverage restorations without those dimples where we used to have over milling. And of course, a football shaped burr to create space in those concave surfaces like the cingulum in the anterior incisors. Something that we've tried to implement as well is better instrumentation for soft tissue retraction for all of those prepping and scanning the same day and looking to deliver the restoration the same day. We know that we need to retract significantly to have a perfect digital impression, but also we don't want to be that aggressive that we could cause something irreversible regarding a recession. So we like to use small instruments, rounded instruments that avoid me impinging the tissue and harming the tissue, of course. And then this is great. This is also from Brasler, from the partial extraction therapy kit. With this is like a shield where I can protect the soft tissue while I refine the margin. Without these tools, for me, it's very difficult to have both, right? A smooth margin, a smooth finish line, but not touching the gum and having no bleeding at all to get the perfect intraoral scan. So as more we get the preps to flow, as less sharp angles, the less the over milling and the better marginal adaptation and intaglio fit as well. So those are important aspects for long-term clinical success. Going back to the VITA Trilux Forte, this is the 1M2 shade, and here we were working on a phosphatic porcelain veneer case. So we get these in a daily basis, some diastemas, some staining on the teeth, some rough enamel after some removal of brackets. And now every time we create veneers, we first think about the final contour of the restorations, the final shape that we want to recreate to determine if we really need to remove tooth structure. And if we are removing, making sure that I have that reference, that stop, not to penetrate into dentin and have enamel guided preparations. So we use our depth cutting burr that it's only 0.3 millimeters because that's the thickness of enamel in the cervical part of these lateral incisors, for example. So we mark them and then we go with the reduction on the three planes, create a homogeneous incisal edge reduction of 1 millimeter. And then when you're working with the most translucent material, remember that we need to evaluate the color of the background of the abutment itself. So whenever I have, like in this case, 4 teeth with very similar shade after the preparation, no problem at all. We can go with Phosphatic Ceramics and that translucency will really create a nice outcome. If one of these 4 teeth is, let's say, discolored and it's very different than the adjacent ones, when we place these thin veneers around 0.5 of a millimeter, we might be able to see a difference because the material has a very high glassy content and it is very translucent. So this is mainly how I try to position the block or the restoration inside the block, having that degradation from the cervical to the incisal, and we have these 4 layers that we like from the VITA Trilux Forte. And then if you're milling your contralateral tooth, the other central, you want to make a screenshot here so you save that information and you can measure how long this cervical saturated area is in this one, so we replace the other central incisor in the same position. And I was talking with Jim after after this year of so many webinars and having the possibility to learn a lot from different people around the world, I really believe that we need to keep working on our hand skills, because we see many clinicians worldwide with the same chairside CAD/CAM system, but what it comes out from the machine still needs more manual detailing to have that nice natural looking restoration. So this is something we will be working with VITA North America next year, a combination between online content, but also working on our hand skills to really improve and have better looking restorations. VITA Accent Plus is the stain and glaze system that I've been using for many years, and it's simple. We have a lot of possibilities, but at the end, what I use is maybe a combination between 3 to 4 stains based on the photos that I take on that patient, but the color is internally in the block. I like to use the finishing agent glaze, which is a very thin and small particle glaze, so we don't lose the texture. So what about bonding? Remember that phosphatic ceramics contain a high percentage of glassy matrix, so we need to apply hydrofluoric acid etching for longer when compared to silicate ceramics. So for hydrofluoric acid, we need to etch for 1 minute minimum, and we could extend to 2 minutes and it will be fine as well. I usually just go for 1 minute as the instructions from the manufacturer say. Then we will rinse very well that, clean it in the ultrasonic with alcohol, and once we have a rough surface and a clean surface, immediately I will go with the Xylene coupling agent. So this is a silica based material, so regular Xylene is what is needed to combine that micromechanical retention with the chemical retention, and that's what will help us obtain longevity on our restorations that we want. But remember that every time we're bonding a restoration, there's two sides in this story, right? We have the side of the ceramic restoration, and also we have the side of the tooth. And the overall success will depend on the weakest side, right? So if I have very strong bonding to the phosphatic ceramics, but I'm lazy and I don't put the rubber dam, I don't put a adhesive on the tooth, then the bonding towards the tooth side is going to be the weak link in this restoration cement tooth configuration, right? So every time we prep for veneers, we try to maintain as much enamel as possible. So we etch the abutment tooth with phosphoric acid for 20 seconds. This is going to be clean. This is going to be rough. We're going to have a better penetration of the next step, which is the application of a bonding agent. I personally have been using the Panavia V5 resin cement system for many years, doing both research and clinical use of the material, and I like it because with that cement system I can cement any type of ceramic restorations that we will be discussing today, and it gives me that simplicity, only one system for everything. But always on the tooth side, for full adhesive restorations, we like to etch the enamel and then apply the bonding agent. This is the tooth primer, and it has the ability to be light cured whenever we need, but also we can avoid light curing it, for example, in cases like inlays, where it's more difficult to control that thickness of the bonding agent before curing it. So it could affect the final sitting of our partial coverage restoration. When we prep for Cerec veneers, I like to prep the facial and the incisal edge. And if I'm not modifying too much the midline, or I don't have wide diastemas more than 1 millimeter, I keep the contact point in tooth, as you can see here, between the lateral and the central. And then this design of preparation gives me that freedom on insertion axis. No matter what material we're using, the main reason we prepare the teeth is to create a path of insertion to fully seat that restoration. Okay, and as I said, with this type of glaze, it has such a small particle, we can maintain the texture. And once I glaze, I always go back and manually polish because natural teeth are not that shiny. Most of the time, I evaluate restorations against teeth, and the crowns, the veneers, the restorations many times look more shiny than the natural too. So this is the type of cases that I like to do, partial coverage, not necessarily 10 or 12 veneers, but trying to improve what we have, enhance the color, while also matching with the adjacent teeth. I think this is something that requires a little more understanding of your materials to have a good selection. So leaving Phosphatic Ceramics, I would like to mention briefly some concepts that we apply with VITA Dynamic. So VITA Dynamic, for those of you that might not have the clinical experience, it's a polymer infiltrated ceramic network material. That's a long and fancy name because many other resin blocks are also called hybrid. So that concept might be misleading. Basically, this is that feldspathic ceramic block, as we just saw, infiltrated with 14% of resin, but those elements are not mixed together. Okay. Also, we have the dynamic in a multicolor block, as you can see here, even with more layers, so the degradation is even nicer when compared to initial Trilux block, where we only had 3 levels of different chroma inside the block. So that's something really good. What do we really like about dynamic, and where would we really use dynamic on a daily basis? For partial coverage restorations. That's my go-to material for inlays, onlays. Why? Because I understand that making a restoration that fits perfectly intracoronally is more complicated than making a full crown. Full crowns, they fit very easy, but an inlay where there's more opposing walls and there's different angulations of the preparation, the stability during the milling is very important. So Dynamic has that 14% of composite that even improves the machinability when compared to feldspathic ceramics, which might be more brittle. They have a perfect dimensional stability because they don't need to go through crystallization. They don't need to go through sintering process. So as I said before, here also what you mill is what you get on your final dimension. And you can mill it very quickly because it's softer for the milling machine, and it has that modulus of elasticity between dentin and enamel. We don't want materials that are that elastic. I mean, it sounds nice to think that dentin is very elastic, but it's more difficult to have strong bonding to something that it's too elastic. So this is a nice in between elasticity and also stiffness that is needed in the materials for indirect restorations. So with one of our residents, we did a nice research study checking if the need of using a fine diamond burr as my final burr, the red line diamond burr, will improve if I just use a medium grit burr, or if an extra fine would have actually a big difference. And we've concluded here that a red line fine diamond burr is needed to provide the best marginal adaptation with milled dynamic restorations with the Cerec system. Why? Because if we use an extra fine diamond, that grit of that burr that we use to prep the tooth, those particles in the burr are smaller than the burrs that we actually use to mill the restorations, so it doesn't make any benefit in that aspect. So the red line fine diamond burr is what pairs better with the diamond burrs from the Cerec milling machine. As you can see here, you can see there the step burr 12S and the cylindrical pointed, and when we measure that, it's around 40 microns, and that's what we have with the red line fine diamond burrs from our preparation kit. You can see here a close-up microscopy image from the VITA Dynamic mill restoration, and there's some areas, Jim, that have 6 microns. It's something incredible, but in an average of 15 microns, that's even better than any of my gold restorations. So the machinability of this material is really, really good. So these are some examples that we use it for inlays, onlays, or overlays. Remember that the thickness is very important, create space where it's needed, and protect from contamination during the bonding protocol are very important for long-term clinical success. So we also like to do direct restorations. They are even more conservative than any type of indirect restoration because we don't need to worry about path of insertion. But when I have a material that I need to cure it to obtain its final properties in the mouth, and we have a lot of volume, a lot of opposing walls, that C factor could cause post-op sensitivity. So we like to combine direct materials to optimize the cavity, to block out those retentive cavities that we can have when we remove amalgams, for example, but then scan and bond something from hybrid ceramic, and we can have very good clinical results. And this is a poster I did with one of my great students, Mohamed Abdulatif, a few years ago. This is what we try to do. We try to work defect oriented. Not every tooth needs a full coverage crown, and if it needs it, well, we can delay that full coverage crown a few years, and we try to use more of defect oriented preparation designs. You can see here this type of inlay, onlay, and one overlay as well, but we have an enamel rim. We are able to place the rubber dam and the clamp very easily because we don't go subgingival. And then adhesive cementation is something that it's not complicated. These I published in the Journal of Prosthetic Dentistry on the effect of surface treatment and cleaning on bond strength to anemic. So here what I was trying to do was looking for the best way to clean it after etching and see if modifying what VITA had as instructions for etching and Xylene and cleaning would improve it. And basically we found out that the application of hydrofluoric acid etching for 60 seconds is the best surface treatment for this material. This is a material that is only available for milling. So actually excessive cleaning after etching was not something that really improved significantly the bond strength. So I'm not saying etch it and work on a dirty surface. No, not at all. But just with water and air spray, removing the hydrofluoric acid etching had the same bond strength that if you did application of phosphoric acid for 60 seconds after the hydrofluoric acid etching. So some concepts that we see that apply for pressable ceramics or layered manually phosphatic ceramic, not necessarily apply for the VITA anemic on that aspect. The good thing is that in these in vitro studies we did, we have cohesive failures, meaning that we can bond very well. So etch for 1 minute, apply a silent coupling agent, exactly the same as we do for feldspathic ceramics, but also protect the bond strength to the side of the tooth as we explained. This is an image on the left side immediately after milling. It's very flat. We never want to bond anemic restoration without the application of the hydrofluoric acid. And on the right side, you can see that we can obtain more than the double of the bond strength because we have this nice irregular surface where we have more surface area and there's better penetration of the Xylene, and those are the reasons that this can be bonded pretty well. Okay, so going back to the silicate ceramics, specifically about the lithium disilicate, we know EMAX-CAD is a very reliable material. Maybe the aesthetic outcomes is not the one that I like the most, but there are other options as well. And this is a case we did a few years ago with VITA Suprinity. So Suprinity is a zirconia reinforced silicate ceramic. As you can see, has the same concept that it's milled pre-crystallized like lithium disilicate, so it's not so hard for your milling machine. We really believe that something that it's less hard during the milling process is something that is going to suffer less, and this totally makes sense for us. So this can come in both translucent color and high translucent as well. Usually when I work with this type of lithium silicate ceramics, I like to use more the translucent. I have a better chromatic result than the high translucent. If I can use something so translucent, honestly, I would be using VITA Trilux Forte block. So when we prep, we want to make sure that our preparations for anterior crowns have smooth transition between the proximal surfaces and the incisal edge. And if you're working on two central incisors, like in this case, I always try to prep as symmetric as possible. If you have endodontically treated teeth, then that's something that we can most of the time obtain without many complications. Shade selection is so important, so we like to base our selection on value. How bright or how dark should the material be? The selection of the block is always based on the value. And when we use VITA Classical, sometimes that's not so easy to do. So if you have any doubt on this aspect, that's where the VITA 3D Master Shade Guide concept helps us a lot. So always consider having both shade guides available. And if it's something you need to double confirm the value, I would always go with VITA 3D Master. Many times as a chairside dentist, I would like to enhance the soft tissue around my final restoration. And to be honest, maybe in my first years doing Cerec, I wanted to deliver always same day and quicker. But now if I'm hoping that these restorations could last more than 10 years. Sometimes I make a very nice provisional and I wait for a few weeks just to enhance the quality of the soft tissue, so I don't have any swelling or inflammation there. I don't have bleeding, and then I can just mill this from the final material, in this case Suprinity PC, and this is the technique that was taught to me by Telmo Santos, a very skillful dental technician from Brazil, from Belo Horizonte, and it's with the VITA Accent Plus. So that's why I always say that we can have many hours of online education, which is great, but we need to get our hands on to be able to get a feeling of the amount of material that I want to apply, how I want to mix the ratio, and how can I stabilize the shades where I need it, if it's something that I could do in one application, or if it's something more challenging, then I might delay it in 2 steps. And of course, understanding the importance of having the information in the program to really get that ideal result are things that we like to spend some time practicing and understanding very well. We could use the vacuum mat from VITA or the Smart Fire as well for crystallization and glazing, of course, of the Suprinity blocks. For those of you having the full Cerec Premium with the Speedfire, it's also possible to crystallize this material and glaze it with these furnace that I really like for zirconia. That's the main use that I give to this Speedfire. So every type of lithium disilicate, whether it's Emax CAT, whether if it's Suprinity or other newer versions that I would like to show you, we have less glassy matrix. We have more of a crystalline phase. That's why these materials are stronger than conventional phosphatic ceramics, so we need less etching time. So 20 seconds is the best etching time for these group of materials, and then they are silica based, so we will clean them well and apply as again a silane coupling agent and go for the final adhesive cementation. So even in these type of more complex cases, we can have very nice outcomes with only staining and glazing. And as I said, try to get a course, try to look for good ceramists that teach simple techniques on staining and glazing. That's what I always try to do, and I feel that my results improve when I'm next to these guys that are really have that ability to not only do it, but to teach you in a way that it's reproducible for ourselves. So I would like just to deviate quickly from the chairside CAD/CAM world, but maintaining myself in the digital dentistry world. VITA now has this new material for lab use for the pressable technique called VITA Ambria, which is a zirconia reinforced lithium disilicate glass ceramic. It can be used for veneers, inlays, onlays, full and partial coverage crowns, and up to 3-unit fixed dental prosthesis, more anterior from the second premolar. So here, because we like to scan, we like to design in the softwares, we actually did a nice combination. This is taken from the website. You can go to VITA North America website and look the material, but we can have posterior crowns, we can have anterior crowns, and also it can be layered for a more detailed final aesthetic outcome. So we created this concept with Telmo Santos, the CAD press technique. Basically, we wanted to follow our same-day protocols using our intraoral scanners, but in this case, we felt that the challenge was higher, so we start scanning, and then we start selecting the shade. You can see those non-carious cervical lesions that are mostly multifactorial. And here, the patient wanted to enhance the shade, but not looking for very bright bleaching shades. So when we are improving maybe 2-3 tones, then we can be very successful with thinner restoration. But if this patient wants to finish with maybe a 0M1, not all the time we can accomplish that at such a thin diameter. So we go ahead and scan this for treatment planning for diagnostic purposes. Once we have the intraoral scans done, we export these to the in-lab software, and there we go ahead and make a digital wax up. Once we have this digital wax up, we can 3D print this model and then create silicone matrix, body matrices, to have the possibility to make a mock-up, of course, but also to use them as prep guides, as preparation guides, to assure that we have the space where it's needed and we are not reducing more tooth structure where it's not needed. So you can see here the preparations. Some of the areas we're actually not even touching the facial aspect because that would be an additive zone, and some of the areas we need to cut out more tooth to have that preparation fit nicely inside this prep guide that we designed from the printed model. Once we scan this, I like to sometimes leave the 000 retraction cord, remove the second cord, dry, and scan very well. You can see here on the palatal aspect, the 000 cord. Just make sure that you don't have this excess of cord very long and going all around. That will affect your scan. But we can scan perfectly, leaving the 000 cord placed in the sulcus. Just make sure that it's not on top of your margin. And then I send this to Telmo, and Telmo started to design the restorations. And actually what he did was to mill from a wax disc, a CAD wax disc, these patterns that were designed in the in-lab software, and then he was able to use the VITA Ambria pressable material, which has a great cost benefit. The cost of production of these restorations is very good because you can press a lot from one pellet. So I don't want to go into these details, but for the people following today's webinar, doing this type of laboratory side, of course, we need to be very meticulous on how we make the investing of these type of restorations, but it's a very clean process for those of you that have the knowledge and have the ability to do this. And then in this case, I asked Telmo to do 2 sets. I think this is a luxury, but when I'm trying a material, I really like to see what can I achieve. So this set of restorations on the left have a partial cutback and have a micro veneering on top. And these ones on the right are just monolithic with his technique of texture and stain and glaze. So I think both workflows can give us very nice aesthetic outcomes. So this type of material, it's like a lithium disilicate. You can etch it for 20 seconds. You can apply the conventional Xylene and do the full adhesive cementation. What I like is that it has a nice chromatic look. It's not gray, the final aspect. And here, what I always try to do is to use the clear trying resin cement. This is from the Panavia V5, which is the cement that I like to use every day. So after trying, we wash the trying, we apply the hydrofluoric acid etching, as I said, for 20 seconds, wash, dry, you put it in the ultrasonic, or you can etch it with phosphoric acid to remove any type of remnants or residues from the etching. Okay, as you can see here, and then we can go ahead and apply the silent coupling agent. This is the Clearfield Ceramic Primer Plus, and once I apply that, I don't want to put any air, I don't want to do anything to that silane there, just let it evaporate and go and start with treating the tooth surface. So independently of what cement system you use, I like to make sure that I have a clean tip, that the material, the base, and the catalyst is coming even from both segments of the syringe, and that I fully feel the intaglio surface of the restoration. So when I place it, I have that flow of the excess 360 degrees around, so there are no bubbles, and there's a really good sealing of this indirect ceramic restoration. So this is the before, this is the after. With Vita Ambria, as I said, it's a nice enhancement without going to a very crazy change to a very bright. In this photo, you can see how nice the final integration of the restorations with the opposing dentition, and this is with a micro veneering technique where there's some layering with the Vita Lumix ceramic, which is the ceramic that is compatible with the Vita Ambria pressable material. So hopefully in the near future, we could maybe have this in a different presentation for some of us that are really like to do the milling and don't have the ability to do all the pressable. This is a great new material. And I always tell my students and my residents and myself that no matter what type of ceramic material, when the patient is asleep, when the patient is stressed and grinding, they are not conscious, and we can have a debonding, a chipping, or a big fracture. So always protect that with a good occlusal appliance. I scan once I deliver the restoration, and I use the inlet software. That's very easy for me to design these night guards, and we now print them, but for many years we were still milling them because of the consistency of that ideal fit. Okay, and today I would like to finish showing something very new on the oxide ceramics group, specifically on the monolithic zirconia. I have the privilege to work with Dr. Marcus Blatz, my mentor, and maybe he's one of the people with more knowledge on the material on zirconia and has been studying bonding to zirconia for many years, and understanding that not all zirconia out there is exactly the same, and that nowadays we have different levels of zirconia depending on the amount of yttria, less yttria, more strength but more opacity, more yttria, more translucency but less flexural strength. And nowadays also we see the mixing of these different percentages of yttria within the same material as well. So we had the privilege to publish a full chapter on this book from my friend Fabio Andretti from Brazil that was just launched last week on digital dentistry for 2021. I'm still waiting for my copy. I haven't received it yet, but here I wanted to publish on the challenge of the single central incisor and what we can achieve nowadays with monolithic zirconia. So you can see here, just by seeing the screenshots from the publication, maxillary single central endodontically treated actually was avulsed, and it was re-implanted. The endodontic treatment was done successfully. Tooth was stable for 10 years, But of course, now the aesthetics were not the best ones, and the patient was not happy with the chipping, significant occlusal access, and the palatal aspect as well. So these are big challenges as chairside dentists, right? And you can see on the other contralateral tooth, a lot of texture, a very personalized incisal third with light blue, with grayish, with white spots, with some orange in the incisal edge, and those are challenging cases. So how do I start when I approach the single central? First thing, before the tooth dehydrates, I start selecting the shade, and I don't need to be exactly sure of what's the best shade, but I have at least one or two good options, and then I take the photos, and in the photo, I do the final decision. I always turn that photo to black and white, and then I can see the grayscale, and then I do the final selection. So then we go ahead and prep. In these cases, with endodontically treated teeth, we still do full coverage restorations. A partial coverage restoration might not be the best, both from the aesthetic side and the functional aspect as well. So here you see the putty matrix giving me that perspective of the three-dimensional space. So the cervical third looks pretty good. The middle third looks very good. The incisal third looks okay. In the facial, maybe just smoothing it out. But in the palatal aspect, that incisal third, I would need a little more reduction there to have a nice concave surface when I'm designing the restoration. So when I rush it and I don't have this matrix, it's difficult to improve the quality of the preparation. So I really recommend doing this, and then I start designing. Remember that for single centrals, you have to check first the mesiodistal restorative space that you have for that restoration, because if it's more than 0.5 or less than 0.5 different from the contralateral tooth, it's going to be very difficult to have a very nice final outcome. So this is something I evaluate always, and sometimes I can use a little bit of composite strictly proximal to the adjacent teeth to distribute the mesiodistal space of my indirect restoration and assure that it's exactly the same width as the contralateral tooth. So nowadays we could also 3D print these models. We can print them quickly. Basically, I just want sometimes to have something to customize the texture, the staining and glazing for these more challenging cases, but it's nothing that I need for every single case I do. So this is the new Zirconia block from VITA, which is the VITA YZ ST. That's super translucent, and it's a multicolor block, and it's available now worldwide. I know that here in the USA, it's going to be also distributed by Dentistry Sirona, but the material is manufactured by VITA. You can use it with the Speedfire. I've had the possibility to be testing this material for a while with really nice aesthetic results. So this material has 4% of yttria and can be speed sintered without affecting the final translucency and the final color when we do mill it dry. So the recommendation, my recommendation also would be to mill it dry, and you don't need to go through the drying cycle. You can go directly to the speed sintering, making the workflow very attractive. And when you see a milled crown on the inside, that's what you want to see, basically a smooth surface. That means that our preparation is good, that we don't have very sharp areas, maybe slightly here, one need of over milling there. So as ideal, the intaglio surface of my restoration, that talks about a good preparation in this situation. Here for single centrals, I always start with the translucent trying paste, and then if I see that maybe I would like to have a little bit more of chroma, then I go with the A2 universal trying paste. This is the Panavia V5 trying pastes, and once I confirm this, then I would go and remove the restoration, clean it in the ultrasonic with alcohol to make sure I remove all the residues of the trying paste, and then go for the adhesive cementation protocol on zirconia restorations that I will explain in a minute. And this is the final outcome. So I'm really excited of having these great materials also available for us, the chairside clinicians. And when we do single centrals, the preparation needs to be done very detailed, the space distribution also. And when we design, we want to copy that tooth not only on the contours, the outside incisal edge position, the volume, but also the position of the line angles, the texture, and the customization of the incisal edge. But this is a multicolor zirconia block that can give us these great aesthetic outcomes. So this was a publication we did on the effect of actually bonding to zirconia. So if we have a conventional preparation design for porcelain fused to zirconia crowns or monolithic zirconia or fixed dental prosthesis, we can use conventional cements because we have retention and resistance form. But if we want to start using zirconia in a less invasive approach, then we need to use a specific pre-treatment protocol and specific primers that are not exactly the same that we've been talking through today when we discuss Phosphatic ceramics, when we discuss hybrid ceramics, or when we discuss silicate ceramics. And this is called the Apc Concept. This was published by Dr. Blatz back in 2016, and basically understanding that zirconium oxide is a material that is not sensitive to hydrofluoric acid etching. So we need to clean it in alcohol in the ultrasonic after doing the try-in, and then the first step would be the air particle abrasion with aluminum oxide particles of 50 microns at a low pressure of 2 bars. Once we do that, we're just going to apply a little bit of air from a dry air source, not having water there. And once we clean it, then we will apply the specific primer. And this primer needs to contain MDP. That's the phosphate monomer that bonds to the oxides, to zirconium oxide, to titanium oxide. So Panavia is the original cement that had this specific primer with MDP. Nowadays, many cement systems have it available, but this is the gold standard. And then we apply the resin cement after the application of the specific primer. Nowadays, there's a new version called Panavia SA Universal, which has the MDP inside the resin cement. So we've done some studies, in vitro studies with Yusuke, a colleague from Tokyo Medical Dental University that spent some time with us here. And we see that new self-adhesive resin cements provided the same short-term shear bond strength values than the gold standard multi-step resin cement systems like the Panavia V5. So basically the MDP is inside the cement, so we don't need to apply it previously as we showed in the conventional Apc concept. So I wouldn't like to extend more than we have planned for tonight, but I hope that with this overview, we are all motivated to work hard on improving the final aesthetic outcome and the functionality for long-term clinical success with the chairside CAD/CAM restorations. I know that having this technology next to our dental chair makes us be much more detailed. And that's what I always try to share to my colleagues, pay more attention to details, and that will give us better longevity independently of what type of ceramic material we are using. Then, as I was chatting with Jim before starting the webinar, I truly believe that we still do dentistry with our hands. And I truly believe that there's a big difference between the final restorations that we see within different clinicians with the same CAD/CAM machine and the same blocks. So we need to work hard on our hand skills, practice, understand the material, have a sequence of polishers and instruments that work in our hands. At what speed are we having the best results when we pre-polish, or when we fully polish, or when we combine with texture and glaze? So all those conversations, I like to have them when we do the hands-on courses, and that's something we'll be working for next year, of course, in combinations with the ease of these type of webinars. And to finish, always deliver what makes you proud. I like to have this very clear in my mind when I'm thinking, okay, I'm going to rush the case. If I'm intending that this restoration lasts 8, 10, 12 years, if I need to deliver instead of right now, maybe tomorrow or Monday, to have a little more time to detail it, to add a little bit of additional stain or whatever is needed to get it to the next level, I think it's really worth it. But of course, I really understand the benefits of not having to provisionalize in many cases, and the benefit that this gives me on the bond strength and on the reduction of hypersensitivity, of course. So having that clinical judgment, I think it's very, very important. So that's the material that I had prepared for tonight. I would like to share my Instagram account. Please ask me questions if you have a nice case you would like to share with me as well. I only dedicate this Instagram page for dentistry, and this is my email as well. If any of you want any of these type of references of the materials that we design with Brasler, or any of the PDF files, or just want to be in contact for future hands-on courses, here are my contacts. And then would like to really thank VITA North America for having me so often this year, and I really appreciate the confidence, and had the opportunity to go back to Bad Sakinen in October and basically reload of new knowledge, of new materials, of new things that we hopefully can share in a mixed online and in-person format next year. So Jim, thanks again for your time, and I'm open for any questions if there are.
All right. Well, thank you, Dr. Canale. That was a great presentation, a lot of good information that everyone can start using right away. So before we get into the questions, I have a few reminders to everyone. If you're going to expect some CE, make sure that you fill out all the information that we sent to you, our education and marketing show. So make sure that you have that. You're going to receive a letter in the mail with all of your information. The recording is posted on our YouTube, North America, VITA North America YouTube channel, and that'll be posted probably in the next day or two. So please visit that website at your convenience. Dr. Canale has done an exceptional library, if you will, of different webinars that we've posted that you can go visit and revisit, and all different topics. We even did digital dentures that they do at UPenn, and several other topics as well. So please join us when you have an opportunity. That's the VITA social media. You can connect us at many of the social media websites. If you need to get a hold of your local rep, please get us a call here, and we'll put you in touch with that. The next webinars that we have scheduled, we have them in November, December as well. Again, so thank you again, Dr. Canale, for providing that information that you've given us. Here's the contact information for here at the help desk, the VITA help desk. Please give us a call or email us. Here's Dr. Canale's information as well. So if we like to get some questions in, so one of them is going to be, how thin have you ever milled out the feldspathic material for a veneer?
Mm-hmm. So that's a great question. I usually go with fine milling mode for every restoration. I never go fast milling, and I never go extra fine. I feel that the longevity of the burrs for extra fine is not not sufficient, and it's just a lot of time consuming. So I always mill fine every material. And with the phosphatic ceramics, when I'm doing the veneers, I never wrap around the palatal side. So the veneer is only on the facial and in the incisal. So there's a better access for the instruments, and I don't see many over milling because of that ease of access. So we can mill these veneers up to 0.3 millimeters. Have I had a fracture during milling something so thin in almost 12 years? Yes, but it's nothing that it's very common. Have I broke one while glazing or finishing or drop one? Yes, but I think the more we use a material, the better we get with it, and then we can start pushing that limit. So yeah, final placement is something very detailed when you want to cement this restoration. So I don't like to use heated composite. I don't like to use very dense resin cement. I like to use that consistency of the Panavia V5, that I'm not obtaining too much pressure against the veneer with this very thin restoration. So yeah, I think you can go up to 0.3.
And like you said, it's keeping our hands busy, right? Always making sure we refine our eye-hand coordination skills and so forth. Another question is, I know you went over it, but can you remind them, how do you clean your crowns after you get them milled? Your restorations. What's your process? Just alcohol, or what else do you use?
So to be honest, I mill the restoration and then I just go direct to try-in. I don't do any specific treatment there. Once I do the try-in, then I have contamination for sure. I have saliva, at least. I have blood there. I have rest of try-in paste if I needed one for a more aesthetic case. So that's where I start to clean. So if I'm etching with hydrofluoric acid, what I will do is that I will rinse air and water, put it in a Ziploc bag with alcohol, and put it in the ultrasonic for 3 minutes. Once it's clean, then I will hold it and I will apply the hydrofluoric acid etching, wash and dry, then apply the Xylene. If it's zirconia, I will do the trying right away as it comes from the Spitfire or the lab, if it's something that was sent external labs, and then I will clean it on the ultrasonic. Once it's dry, we will go ahead and do the air particle abrasion. Remember that air abrasion, the benefit is not only micromechanically, it's also creating a very reactive surface. So when you apply this MDP component, it's going to have a better distribution. If you remember from physics and all that, contact angle and how a drop can stay, or how a drop can actually, I don't know the word, but distribute better on the surface, right, and have a better wettability. That's something that fresh air abrasion does. So the next question, Jim, could be, so do I need a Sandblaster, an air abrasion instrument in my clinic? I would say yes, if you want to do bonding to zirconia. And when we do implant supported restorations with zirconia, with tie bases, I think that having a Sandblaster that you can calibrate is something that is very, very useful and important. So after air abrasion, I will just apply the primer. As I said, I will leave it there for a few minutes while I start getting ready the tooth, and then we will go ahead and apply the resin cement. Things that I consider important, Jim, is the technique and really getting to know the system. So I've been using this resin cement for many years. We've discussed about this cement, and there are many others that are really good, but sometimes I see clinicians jumping from one to other, or I go to a dental meeting and I hear someone using something else and then I try it. And what I see is that we never get to really give us the time to know the handling and create a very smooth cementation technique. So I'm not like shopping around on every ceramic, every resin cement that it's out there. I like to see and update myself, but that part is very important. Knowing the timing, knowing your materials.
All right, great. Another question is, if I over etch, or I know that I've over etched, how can I still use that same crown, or do I have to remill? How would I fix that? How would I?
Mm-hmm. Yeah.
Is that a possibility?
You know, it's a very good question in a way, but I could answer it in a very basic way. Like, I mean, just don't over etch. Get your cell phone, get a timer, and just, you know, be very detailed with that. Know your numbers. So Phosphatic Ceramics, 1 minute. Hybrid Ceramics, 1 minute. Everything with lithium silicate, just 20 seconds, right? There's different studies there that show that over etching is not that catastrophic, let's say. Do I know the limit where over etching is going to be catastrophic? I don't know. That would be impossible to really answer in a very honest way with scientific evidence, because we would need to see the composition of the hydrofluoric acid etching, whether it's 5%, it's 9%, what specific material is there. So we don't like the lab to do any type of etching or air abrasion, because then that's where these over etching can happen, right? Or over air abrasion can happen. So we mill in-house, or if we send out, we take care of these surface treatment previous to the bonding, and then we know that we are the first ones doing these procedures, and we can control that.
All right. Another question is, although the machines usually tell you when the burr is no longer usable, do you use that warning, or do you count how many crowns you mill and then switch your burrs out routinely? Or do you go by the system and what the system's telling you? Hey, it's time to change out your burr.
Yeah, great question, and I'm going to be very honest here. We know that there's a reason why that warning happens, but also we understand that the software manufacturer and hardware manufacturer and R&D departments try to always cover themselves, right? So if I see the warning for the first time and I'm in the middle of a milling, I will just hit OK, but continue with the process. If I can change it right away, so the next restoration and milling that doesn't come up, then I will do it right there. But I don't like to go into, okay, let's see how many more restorations I can mill when it's telling me. So at the end, I want to be practical. If it started the job, I would like to push it to finish it, but I don't want that to be disturbing me as I continue the same day milling out restoration. So I would change it. So it's kind of an in-between.
Yeah, that makes sense. Another question is, when you have two centrals that are not ideally the same shade to begin with, what do you do to match them up, or do you use the materials to compensate for one discolored central versus the adjacent central?
If you send me an email or a message, I can send you the PDF. We published on Quintessence of Dental Technology in 2020 an article on cases of maxillary centrals. So when we call it a straightforward case where both of them are similar in shape, the preparation can be managed, the shade as well, we can use a monolithic solution. But sometimes we have very difficult situations where maybe one of them has a metal post and core, or one of them has a very intense discoloration, and that's where I believe that we need to combine materials. If you remember, Jim, we discussed and we presented this in a past webinar, and that's the great thing of having the first generation of zirconia, the 3% yttria stabilized zirconia, that is very strong, it's very opaque, so we can mill this very thin sleeve of around 0.3 of a millimeter, and then with that we can correct any type of discoloration, and on top we go with a nice phosphatic ceramic material. What we do with this custom coping is that if I have an adjacent veneer, I will design this custom coping to have the same length and width that the adjacent veneers preparation. So when I bond those two veneers, they are symmetric. They have the same length, same width, same thickness, and that's how we can correct that. I've seen clinicians painting the abutment with a type of opaquer. I don't like to do that. I don't feel that I have complete control, and I like to be able to check what's the color of the adjacent tooth, the adjacent preparation, and if it's an A1, I will mill that custom coping from an A1 zirconia, and then I'm start matching from the inside. If we go to a natural tooth and we section it, we see dentin inside and enamel on top. We don't see any opaque resin or opaque material in the dentin. Inside we have more chromatic, so that's why sometimes I feel that applying those painted opaquers are kind of against the design of how the tooth is built. So yeah, I can share that publication. I think it's a nice technique that I don't do 100% chair side, right? That I would send to design that custom, deliver that, then we scan, and then I can go with my two veneers.
All right. I know you covered it, but there's another question on what is used for air abrasion. I think either if you just repeat your particle size, and then do you have any specific equipment, just an air abrasion unit?
Yeah, so we use aluminum oxide particles, 50 micron size of the particle. We need to have a air abrasion device that you can calibrate the pressure and actually measures the pressure. We've been using for many years the Remford air abrasion devices, and they work very, very good, and you can really see a very clean distribution of those particles. Also, the downside is that the glass part, after using it, gets like grayish, and then sometimes you need to change the glass. I think that happens with any other system. Jimmy, you've seen others, but that's kind of the downside.
You mean the glass edges?
No, yeah, exactly. The glass that protects your hands, after a while, it gets like foggy. So we've had to change those, but those equipments work very good. Yeah.
All right. Last question here is, at UPenn, what are the types of mill systems you work with, and how many do you guys have there?
Yeah, so we have mainly Cerec milling machines. The milling machines that we have are the MCXL, and we have some that we use for wet only, and the ones that have the ability to use with the vacuum for dry, we only use it for dry. I know in a private practice, I didn't have this luxury when I was only in private practice, but we understand that having a dedicated machine to dry mill zirconia will really get you those final results on the translucently, independent of the brand of the type of zirconia. Wetting the zirconia and drying it in the furnace and sintering does affect the translucency levels on that. So that's something I would consider. Looking forward to have the prime mill. I don't have it yet, but I've been working with it in courses or where I've taken some trainings, and I think that has a great potential on more of the materials that we're milling actually today. And then we also have some bigger machines, more for the lab side. So we combine the chair side part with a full scope of lab side milling. So we have different types of milling machines. We also have for chair side, we have the Planmeca mills as well.
All right. Well, this concludes the webinar. Do you have any last comments you want to make, Dr. Canello, to the audience, the attendees?
Yeah, no, thanks again. Thanks for joining us. And hopefully we can next year have this combined format that Jim was mentioning. And as a big Costa Rican follower of my soccer national team, I'm just going to watch the qualifiers right now that are getting very, very tough. So thanks again for having me, and enjoy the evening.
Well, thank you. I appreciate all your time and all the effort that you put into these webinars. Again, if everyone wants to visit the VITA North America website, YouTube channel, you can see tonight's recording of Dr. Canello, along with another 5-6 additional webinars that Dr. Canello has graciously provided us. So I want to thank everyone for attending. Thank you, Dr. Canello, for your time again. And this concludes today's webinar with Dr. Julian Canello. Thank you.
Thank you. Good night.